please stay muted if you're not wanting to be recorded, and then please do stay muted throughout the presentation. So I'll just give you a moment now to do the Menti, and then we can move over to our first speaker.
The Menti is in the chat box at 2:27 if you want to find the link.
Great, so we'll move on to our first speaker, which is Charlene Mulhern. So Charlene is the Mental Wellbeing System Lead in the Greater Manchester Health and Social Care Partnership. Her current role is, in her current role, she's responsible for enhancing the profile and response to improving mental wellbeing in Greater Manchester. In current and previous roles, she's had responsibilities for working at national, regional and local level across organisations. This has involved supporting systems on implementing evidence-based public mental health prevention and promotion plans. She'll speak to us today about conducting a citizens panel to highlight community mental wellbeing needs in Greater Manchester. Over to you, Charlene.
Thank you, and I'll move on to the next slide, that'd be great. So yeah, my presentation is mainly going to focus on the journey across GM around mental wellbeing, and also summarises, you've mentioned, Neha, around the mental wellbeing conversation. So I should say that this is a relatively new programme with activity starting about 12 months ago now. So briefly, just to set the scene, in Greater Manchester, what we have is 2.8 million people living in Greater Manchester, or GM, as I'm going to refer to it as. And what we do know is that 1 in 6 people will have a common mental health problem. And so in Greater Manchester, that's 500,000 people. And although time doesn't allow us to go into the detail around the data and prevalence, what we do know from the wellbeing conversation that I'll dive into is that two-thirds of individuals basically don't feel connected to their community. And what we also know that a quarter of adults do less than 30 minutes of activity a week in GM. And from a mental wellbeing perspective, and the 5 ways to wellbeing around connect, be active, take notice, learn, give, we know how important these things are for our wellbeing. So of course, the mental wellbeing programme is cross-cutting, and my role really is to strengthen the mental wellbeing offer across each and every programme and policy across GM, and so it's no mean feat. And you'll see on the next slide is how I believe we've started to create that public mental health approach in GM, and it really does kind of recognise, now we are at that point where we're starting to recognise that shift towards kind of the focus from treatment to now prevention and early intervention and resilience. And so the levers that I've basically used, and these link really closely to the Prevention Concord Act, because we're also a member of the Prevention Concord Act through Public Health England. And the levers that I've used in GM have focused around creating that collaborative system leadership and the right public mental health expertise. And so we do have a senior mental health advocates across the system in many, if not all, sectors now at this point. And we've even got the Mayor of Greater Manchester that's a big champion of the work around mental health too, which is fantastic. We have a mental wellbeing executive group that consists of GM system leads and locality leads as well, that basically help us to shape the direction of travel of the programme, with the main focus being on tackling inequalities. And then along with clear governance structure, we also, which has allowed me to secure basically over £2 million in funding over the next 3 years on improving mental wellbeing. So we know that tackling inequalities is crucial, but more than ever, what we need to do around mental wellbeing is to understand the needs of citizens. So when we move forward on to the next slide, you'll see that a big part of this was around the big mental wellbeing conversation, where we captured over 4,000 responses of individuals. And what we really learned was that mental wellbeing is really important, and 97% of individuals highlighted this. But what was a real concern in the data that was shared was that respondents were indicating that they weren't sure. So almost half of respondents were indicating that they weren't sure or didn't know what to do to support their mental well-being. And then when you looked at the demographics in certain groups in particular, that this was even higher for certain groups like BAME groups or men, those indicating that they had a disability, or those renting from housing associations. And then I've mentioned about the 2/3 of individuals that didn't feel connected to their community. And I think from a public health approach, we know how important it is to be socially connected to your community and neighbourhoods, and those that have fewer mental health problems according to the evidence, and so therefore this is a real concern for us and what we want to do work on going forward. Another question we asked was the 401s questions. And really with that data, like it's alarming. It just indicates that just far too many people across Greater Manchester are not very happy, do not find life satisfying or worthwhile, and have high levels of anxiety. And really, there is just so much data, and I don't expect you to read any of the graphs I put on this slide because there was so much data in the short time scale I have for presenting. I can't go through it in the detail, give it the justice, but I have included the link on the slide so you can actually go through the report yourself in more detail, and I'm more than happy to share the questions for those interested in doing something similar in their localities. But really what we're doing with the data now going forward is we're basically using it at GM level and a locality level to influence the current and future decision making going forward around supporting mental wellbeing outcomes for the GM people. And so even though it seems like a really simple project to do a survey, it actually has proved so effective to create a lot of noise in the system around communities of interest in and tackling inequalities. And from speaking to many leads across Greater Manchester, it's not that the data that's presented is anything that's massively shocking. There are some things that I found interesting, but it's really that now we actually have the data and we can now evidence what we need to do and push forward. And so in terms of investment, I can honestly say where normally I feel like we have to negotiate and really influence around what's needed around securing funding, it's actually felt for me really effortless like to take forward the funding proposals this year because we had a real clear rationale linked to the need. So if I move on to some of the things that we have commissioned. So what we have taken forward was Connect 5, and for those not aware, Connect 5 is an evidence-based public mental health promotion training package. And so evaluation has basically shown it to increase confidence and core skills of frontline staff so they're more effective in basically having conversations about mental health and wellbeing. And so we've done this through commissioning a Train the Trainer contract around Connect 5. We then also commissioned what was the Mental Wellbeing Grants Programme, and this has funded a wide range of programs, micro, mini and small grants, and the themes that we've funded has basically been around training to staff, volunteers, purchasing digital equipment, licenses to effectively move online on the back of COVID, providing beneficiaries with resources and materials to enable participation. The Living Life to the Full is our digital offer across Greater Manchester, and this is our free online courses covering low mood, stress, resiliency, enjoy your bump, baby, toddler, and basically the whole host of material on there. And we translated it across 15 different languages, of the most common languages in GM. And then we also realised digital isn't for everyone, and to respond to the digital divide, we actually disseminated hard copies of the books across GM based on needs identified by the voluntary community sector and also by locality hubs. And then finally, what we've also done is commissioned an evaluation, and that we've commissioned Cordius Bright to take forward an evaluation around the commission activity. But what's really exciting is we're also working with them to pull together and establish a baseline measurement around mental well-being, so we'll have a framework that we can measure success going forward.
Charlene,
and then
finally,
finally,
7 minutes now, so if you
can I just do
just quickly round up that.
So and then finally, just to sum up, the mental wellbeing programme focuses on continuing to build capacity and capability in the system, bolstering the BCSE sector and arts, challenging stigma, strengthening system leadership, and then it has tackling inequalities throughout, and that's our focus over the next 3 years. Thank you.
Thank you, Charlene. That's a great note to end on, and really great to hear how that survey has helped you can capture the community voice and enable policy changes. I'm going to give people a moment here to just reflect on that and to put in any questions onto the Menti, and so just have a moment to do that before we move on to the next speaker. So I'll just introduce our next speaker now. So we've got Stef Keeble, Stef is the director of Birmingham LGBT. She's worked in the community and voluntary sector for over 20 years. In 2018, the charity of Birmingham LGBT became one of 8 King's Fund Impact Award winners, recognising the impact the organisation has had in improving health outcomes for LGBTQ people. Before moving to Birmingham, she was the CEO of a domestic violence charity, where she developed a network of survivors groups, a 24-hour crisis advocacy service, and a service for ethnic minority women. She's passionately committed to human rights and social justice and has always worked to create a better and more equal society, including through championing grassroots community activism. Today, she's going to speak to us about assessing mental wellbeing needs in the LGBTQ+ community during COVID-19.
Thank you. Just wait for the first slide. And the next one. Lovely, thank you. Okay, so I'm just going to give people an overview of what the issues are, what the health disparities are within the community. And then I'm going to talk a little bit about a piece of work that was commissioned by Public Health Birmingham to look at how to work with communities to get health promotion messages out, re the impact of COVID-19. So looking at mental health in the LGBT+ communities, LGBT health in Britain, Stonewall 2018 found that half of LGBT people, 52%, said they'd experienced depression in the last year. 1 in 8 LGBT people said they had attempted to take their life in the last year, and that was people between 18 and 24. 46% of trans people had thought about taking their own life, and 31% of LGBT people who aren't trans said the same. 41% of non-binary people said they'd harmed themselves in the last year, compared to 20% of LGBT women and 12% of GBT men. 1 in 8 LGBT people have experienced some form of unequal treatment from healthcare staff because they're LGBT, and almost 1 in 4 LGBT people have witnessed discriminatory or negative remarks against LGBT people by healthcare staff. 1 in 20 LGBT people have been pressured to access services to question or change their sexual orientation when accessing healthcare services. So some form of conversion or aversion therapy. If we could move on to the next slide. A number of theories have been put forward to explain this, including minority stress theory, May 2003, who argued that the impact of stigma, prejudice and discrimination create a hostile and stressful social environment that causes mental health problems. The model outlines stress processes, including the impact of prejudice, discrimination, expectations of rejection, hiding and concealing, internalized homophobia and adaptive coping processes, so things like substance misuse. The model emphasizes the impact of institutional discrimination, external heterosexism and cisgenderism, and growing up in a heteronormative society where heterosexuality is assumed to be the norm, and its impact on health outcomes for LGBT people. And then the other model, internalized homophobia, biphobia, transphobia, looks at how people swallow messages or these microaggressions that are there externally and take them into themselves. So how they internalize the homophobia, biphobia or transphobia that they're growing up with. If we could just move on to the next slide. So which one of you is the fork? So that's sort of the experience. Got 2 chopsticks and a knife and fork there. And that's a sort of exploration of what heteronormativity feels like. So if we could move on to the next slide. Last April, just quickly, I've done an overview of what's an asset-based approach, which is we operate a holistic model of well-being when we deliver services based on the strengths within communities. I'm not going to go into that in a lot of detail, but the model is based on co-production with members of the community with lived experiences. I'm not really going to talk about our services today, but wanted to talk about the impact of COVID-19 on the community. So last April, we were commissioned by Public Health Birmingham, and they commissioned a number of community providers to work with them to deliver messages around the impact of the pandemic to the communities they work with. can we move to the next slide, please? In order to do that, we carried out a number of pieces of research. So we carried out 2 focus groups, one with LGBT people and one with trans and non-binary people, where we spoke to 18 people. And we carried out a survey and commissioned somebody to write up the research from that. And we had 158 responses to the survey. We found that LGBT plus people were facing additional barriers during COVID, with LGBT plus spaces closed and limited access to community spaces and support networks. So the bars were closed, community groups are closed, community centre was closed. And what came out of the research was that the 2 main concerns people had were isolation and financial worries. A quarter of respondents felt they were unable to be their authentic self since lockdown. People were struggling to access online support because of issues like privacy, i.e. if they were locked down with an abusive partner or family member, or if they were out to the people they were living with. And we had a number of people who couldn't access online support due to digital poverty. A quarter of respondents felt they were, I've just said, so 70% of respondents felt their mental health had been significantly affected by the pandemic in the last month. 63% had felt depressed, 77% anxious, 64% had felt lonely, and over 13% had felt suicidal. And I've got a quote here: "It's lonely, the support of the scene and social groups is missing. Some of the groups haven't transferred to the COVID world." And unfortunately, we have had a number of suicides. So how did we respond? We trained volunteers and set up a befriending service so that they could phone people. We received funding to increase our LGBT affirmative counselling service. We had a grant from Migrant Exchange so we could provide data packages and netbooks to asylum seekers so we could get them online so they could access support. We set up more online social activities like poetry workshops, coffee mornings, quizzes. We increased activities that build resilience and coping strategies, which included online yoga, mindfulness and meditation. And then we also developed an online health promotion campaign to support LGBT people in the lockdown based on our findings. So that was what we were commissioned to do, was the campaign and the messages, but we did something much wider because we were expecting a mental health pandemic and still are coming out of this. And when we looked at the messages, we came up with 3 main campaign messages. Which was stay safe was the first one. The design, we chose not to use a rainbow flag, but we've used the colours of the new inclusive rainbow flag. We went for a sort of bubble design because that had become associated with COVID. And the first one, stay safe, is looking at messages that says if you develop any symptoms, get tested, stay at home, self-isolate. Have the next one, please. Just had a warning, retime. So take care of yourself was the second theme, which is looking at physical health. And then the third one, if we can move on, we called You Matter, and these were messages around people's well-being and staying connected. So we have not forgotten you. Isolation during COVID-19 can negatively impact mental health. We're still offering services and counselling. We're here for you. These are the messages around mental health are the ones that get shared the most and people interact with the most. So this was the sort of most powerful one out the messages. And I'll stop there. I think I'm at time. Thank you. Thank you for listening.
Thank you so much, Steph. Really great to hear how your work has outlined the important relationship between isolation and identity within the LGBTQ+ community and enabled you to make timely change. So once again, I'll allow people to have a moment to reflect and to post some questions on Menti and to like any questions from the previous speaker before we move on to our next one. So I'll introduce Chanelle Myrie. Chanelle is a Senior Research Fellow in the NIHR Pre-Doctorate Fellowship and also a Clinical Psychologist at King's College London in the Institute of Psychiatry, Psychology and Neuroscience. She's a psychologist and a researcher with a special interest in experiences of psychosis and the mental health of ethnically marginalised communities. She has experience both as a clinical lecturer and in various NHS posts in leadership and management roles. As a therapist, Chanelle is particularly interested in exploring issues of intersectionality and identity, and she actively attempts to destigmatise mental distress by designing and delivering accessible and acceptable therapeutic interventions to individuals, families and groups. Today, she's speaking about her work with young Black men and promoting mental health.
Thank you. Hi, everyone. So I've got 7 minutes today to talk you through a community-based co-produced project I led on last year, which focused on young Black men in Lambeth co-producing their own wellbeing intervention. I also want to acknowledge the input of Taiwo Aziz, who was the research assistant on the project, and Siddiqui Harris from Black Thrive, who's their communications lead, and to say we all delivered the project together. And that this project was a partnership between Black Thrive, a third sector organisation focusing on Black mental health and wellbeing, and the trust that I work for, South London and Maudsley NHS Foundation Trust. So this project was hosted within the mental health promotion team at South London and Maudsley. And the team specifically focuses on mental health preventative initiatives. So that's usually by way of teaching, training, small scale community projects. And I previously completed some research that looked at young Black men's conceptualizations of wellbeing. And in this, participants had spoken about what was currently on offer in mental health services as not being seen as supportive or promoting what they felt was important for their wellbeing. So we thought, why don't we ask Black men what they would actually like? It's also important to add that this project was funded by Lambeth CCG, who were very supportive, despite, as a co-produced initiative, not having any idea what the outcome would be. So the project was divided into 3 phases. The first phase consisted of interviews and focus groups of young Black men in Lambeth. And this was to explore their ideas about possible wellbeing interventions. But in addition, we were interested in exploring the form of these interventions and what would have to happen in order for them to be seen as accessible and acceptable. So this included aspects such as thinking about who should be facilitating the intervention, where the intervention should be based, and other important issues that might not necessarily be focused on currently. It's also important to add that initially we decided to hold 4 focus groups, so one for young Black men aged between 18 and 24, one for 25 to 35-year-olds, one for men who identified as LGBTQ+, and finally a focus group for people working in community organisations supporting young Black men. However, we ended up being contacted by men who wanted to take part but didn't want to join a focus group, so we offered individual interviews as well. And once we completed all the interviews and carried out a thematic analysis, we made a list of all the different interventions which were suggested, and then we moved to phase 2, which was to list all the interventions in a survey and ask Black men and the general public to vote on which 5 out of the 34 interventions suggested they would like to see on offer. Once the survey closed, we identified the most popular intervention, which actually was individual therapy. And then we reconnected with the young Black men that took part in the initial focus groups and interviews to help us design the final intervention. And we were able to recompense the men that took part in the interviews and design sessions with vouchers for their time and their input. So one of the most important issues that came out of the interviews was the importance for Black men to have safe enough spaces to access in order to engage in activities which they thought were going to be beneficial to them. And through the interviews, it was apparent that statutory services were not generally seen as that place. So I'm now going to very quickly summarise some of the key themes that came from those interviews. Thanks. So relatability. So Black men spoke about the importance of speaking to someone who understands their lived experiences and the socio-cultural context in which they live. But there was also the importance of connection and a certain amount of exchange, give and take within the supportive relationship. The next theme was authenticity, which was particularly present in the LGBTQ+ focus group. That's the inability of mainstream services to be aware of the intersectionality of someone's identity and the implications that this might have for mental health and well-being, and that this prevented Black men from being what they called their authentic selves. There was also lots of conversations regarding visibility, and this took different formats. And so it included the visibility of the particular form of the intervention. So that's the importance of the intervention being present and known about long before someone felt that they might need to access it. But there was also the idea that just by seeing narratives of marginalised discourses or hidden stories relating to Black men, whether this is explicitly connected to mental health or simply more generally, that this could be really helpful for self-identity and for well-being. Here's a quick look at some of the leaflets we used when we were asking people to take part in the project. And some really useful feedback we received was the importance of the design of them. So people really liked them and felt that it was important that care and attention had gone into them and that they were clearly designed with their target audience in mind. So although I'm presenting today by myself, I just wanted to reiterate that this was very much a team effort. And so I've got some thoughts and reflections from Tyra and Siddiqui here as well. But from my perspective, this project really brought home the importance of partnership working, both in terms of co-production, but also in terms of building and strengthening relationships between third sector organisations and statutory services. I believe there's a lot that statutory services can learn from third sector organisations in terms of accessibility and creating safe spaces, particularly for Black men. Okay, sorry if that's been a bit rushed, but thank you very much.
Thank you so much, Chanelle. And I think those pointers on relatability, authenticity, visibility and design are really helpful tools to think about how we build relationships. So for the audience as well, please take a moment to reflect and to post any questions on Menti before we move on to the next speaker. So I'm going to start introducing our final speaker for today. So finally, we have Amna Rahman, who's a research fellow in the Born in Bradford study. She works specifically on engagement within the family of birth cohorts. She joined the team just over 4 years ago and works closely with the Born in Bradford lay participation groups and local communities on various engagement strategies. She's also the study coordinator for the Healthy Happy Children's Priority Research Programme. She's going to speak to us today about her experiences in engaging and researching with diverse communities.
Thank you, Neha. So our approach around diverse communities and engagement is based on a few simple facts. So first of all, Born in Bradford is birth cohort in Bradford, which is now in its 14th year. We've been studying the lives of 30,000 Bradfordians. There's about 13,500 children plus 12,500 parents, but that was the original cohort, which has now ballooned into lots of different other cohorts. Some are to do with children and others are sort of more wider generic community research projects. So we've realized that the one size fit approach doesn't fit all. So we've had to think about our community engagement strategies and how in terms of, is it fit for purpose? Does it serve all our communities? We know that some communities are easier to engage and they come to us, but there are others that we have to work to engage. And so it's a case of going to them. So we need to have various communities on board in terms so that we can ensure that we've got a broad spectrum of views that are heard and understood. And one of the ways that we do this is by using lay research groups. We've got a few various ones with adults and children. The lay research groups act as useful platform for us in terms of consultation, review and feedback, but they also, what they bring to us is the experiential knowledge that they have. So obviously, as researchers, we've got the epistemology, the presentational, the propositional knowledge, but we don't always have the experiential knowledge, which comes from communities, and it's their lived experience and their lived sort of worldview. So when we, that's one platform that we're using. So moving on to how we disseminate our findings. Obviously, we're a research project, so like others, we have lots of papers out about our research. We use social media in various platforms for various communities. We use newsletters, blogs, booklets, etc. But national media, we've been fortunate that national media, particularly Radio 4, BBC, have followed us right from the beginning. But more importantly, it's about utilising the local media that's here in terms of radio, newspapers, community magazines, etc. But pre-COVID, we had a very strong face-to-face community engagement practice where researchers like myself were out and about quite frequently. It gave us an opportunity to interact with the public, and it gave the public an opportunity to see the researchers that were researching them. And that face-to-face contact, obviously very important. I think it's probably number one in terms of our engagement. But then obviously the pandemic's hit and we've had to readjust things, and a lot of it's still carrying on, but they're using other tools, social media, online platforms, etc. But the engagement that we have with the lay participation groups has still continued. And what we're asking, obviously they've got experience of being parents in the cohort, parents of children in the cohort, but they also all live and work within the district. So they've got lots of useful networks. So what we've tried to do is disseminate messages through them. So I don't know if you can see my pointer, but this little message here with saying 2 in 5 is a WhatsApp group message that's been generated from one of our latest studies around COVID and its impact on our families. So these our lay participation groups are able to send these messages on for us, which sometimes they're sort of better received from people that are known to people rather than coming from outsiders. So that's just a little bit of the dissemination. But in terms of impact and how we know, how do we know what we know and how do we know if it makes a difference? Obviously, we have all this information that's accessible to communities, professionals, faith groups, etc. But the other aspect of this is how we can influence policy change and decision makers. So, sorry, can you go back to the yeah, that's fine. The perinatal mental health, which is, we've just recently worked with another organisation. Previous data was showing us around 20% of women were saying that they experienced some kind of mental health issue in terms of the perinatal period. But our practitioners locally were telling us that that felt a little bit low. Obviously, they've got experience of working with communities and they know what they, you know, the feedback they were being given. So what we've done is we worked with various different services that are working with women in this area and try to create a data sharing record, which is where different people different organizations, services could feed in at different times in that woman's journey through the perinatal period. And by linking all these services and the data sharing, we managed to create a single indicator of poor mental health in the post-perinatal and postpartum period, which combined with other records that were collected, research data that was collected by researchers, as well as interviewing professionals who were working with that, the figures now state that, in fact, it's over 50%, or more like 55% of women who actually experience distress during mental distress during pregnancy and postpartum. So obviously there's a big leap there, and we've tried to analyze what's happened, you know, in terms of, you know, obviously having a shared data record is improved the statistics, etc. But what's happening? Why, you know, why is this a big leap? We've got, so women were telling us that some communities weren't reporting it due to stigma, repercussions, cultural differences, etc. So that's one way where we've managed to influence change by creating a shared record. But other ways where we've worked previously about how we've managed to influence policy and practice is around, we do feed, it's applied health research. So all of our data does get fed into relevant things like the council, NHS, CCGs, commissioners, policymakers. So the recent research, I mean, 1 year ago when we went into the pandemic, a lot of our research focus went onto the COVID research. So a number of us were tasked with getting community data from communities about soft intelligence of how it was impacting them. And that went, it fed in, as a report fed into District Gold Command, which was the local authorities' strategic sort of planning around COVID. But it's also fed into our research around COVID. It's built up, you know, we've had 2 rounds of COVID family research studies now, and we're about to embark on a 3rd one. So that's the kind of impact that research is having. But previously, prior to COVID, I mean, a lot of our research does get into policy and practice. The research that we did on air quality went as far as European legislation on air quality, and more locally into the council's planning around clean air zones, and getting the bus authority, well, the metro transport authority to.
Amna, your time's up at the moment.
Okay.
So you could round up.
Okay, thank you.
Oh, great, you're finished. Thank you so much. That's such a wealth of insight in terms of innovatively working with communities, both at that local level and thinking much wider in terms of services and national and regional policy. So great, that's great to have you there. I'll now move on to Stef, and she can lead the question and answer session. The Menti will still be open for you to post some like questions. Sorry, I don't think there's too much more opportunity to post, but we can do some for the last speaker.
Okay, brilliant. Thank you very much, Neha, and thanks very much to all our panelists. As Neha said, you can still go into the Menti and you can choose to like some of the questions. We'll start with Charlene. There's been some questions about the hierarchy of research in public health and the traditional evidence hierarchy. In particular, is there a role for qualitative research within public mental health? Is this kind of evidence valued among policymakers? You spoke quite a lot about the survey being valued by policymakers and how it made your lives much easier this year. What about qualitative research?
So it was both quantitative and qualitative, the digital survey, and it was a digital survey. And so what we had is we had some obviously quite easy findings that we were able to, what I shared with you around kind of numbers, but we've got lots of themes that have came out, and then we were able to unpick it based on different demographic groups. So and it is like policymakers, yeah, it's definitely creating lots of waves for policymakers and program leads. And I'm presenting even next week to the GM Disability People's Panel that's chaired by the Mayor, who's really interested in the findings just around their demographics alone, around the themes that have came out. So, and I've been sharing it across the different demographic groups because I've been breaking down the report to be able to share it, to influence, not just because as a system, it's not just about what we can do around mental well-being, it's about how we can embed it into everything else. So there is appetite, and localities and across GM and policy leads do want to use any data. The thing is, we got it evaluated, and we did that thematic analysis to make it more kind of easy and tangible for policy leads to kind of pick up and do something with it. So I think that's always helpful.
Thank you. And we have a question for Stef. Stef, what were the differences in the data in relation to different ethnicities racialized as BME compared to peers racialized as white in the research that you did?
Okay. Well, one of the things that came out quite strongly, both in the focus groups and in the survey, was that the people who were probably experiencing the most problems in terms of poverty and inequality were people from what you've described as BME communities. Probably the most vulnerable people were people seeking asylum. That was the group of people who were finding it very difficult to access online support, because we'd moved from having a health and wellbeing centre, a community centre where we offered a range of services from sexual health promotion through to giving community groups space to meet, to suddenly everything, trying to offer services online. And I actually, which shows my privilege, I hadn't even considered that some people wouldn't have access to Wi-Fi or an internet connection. So we found that where there were concerns about finance or food poverty, this was more likely people from BME communities. And this has been reflected in some of the services we run. So we have two BME workers who work with Black African, Afro-Caribbean men who have sex with men and Asian men who have sex with men. And what those groups had found was that the service users were more likely to be struggling and need food banks or losing their jobs, more difficult sometimes to self-isolate because might be living in overcrowded accommodation. We also saw quite a big increase to our IDVA service. So we run an independent domestic violence service, and about 20% of the referrals to that service are for forced marriage or honour-based violence. And again, we saw an increase in this because what we were finding is that people were more likely to be living in an environment where they couldn't be out. And this wasn't just coming from the research, this was coming from service users that we were working with. So what we found was that there were higher levels of poverty and inequality where there was intersectionality, if that makes sense. I think there's a bit of a myth out there about the pink pound. Everybody thinks that people who are LGBTQ have lots of disposable income. There may be some people who fit that stereotype, but lots of people don't. We've been giving out food parcels throughout the pandemic to people who are really, really struggling. So I think that was one of the things that came out, was that there was more likely to be just as likely to be isolated because they may experience homophobia, biphobia or transphobia from their communities of geography or their communities of race, and they may then experience racism from within the LGBTQ community. So sort of double discrimination, but also more likely to be experiencing things like poverty and inequality. That was what we found. I hope that helps.
And how does that translate into influencing the kind of public health evidence?
It's interesting, the question around public health evidence, because what we've certainly found in the past is we'll go to organisations like Public Health or the NHS and we'll say, these are the health disparities, and they'll say, where's the evidence? Because nobody's monitoring and collecting the data. And then we'll provide some data. So we were commissioned by Birmingham City Council in 2011, and Public Health decided that was a needs assessment because it wasn't rigorous or academic enough. So I think one of the things that's important is people listen to the data that communities are bringing. This particular survey, Public Health actually took our data to include in their research, and they asked us to put their questions in it. So I think it started off a much smaller survey and ended up 113 questions. And some of that was because we'd put information about support services that were still running in it, because some people wouldn't know how they could access support. So I think one of the things that's really important is that the Public Health and the NHS and statutory bodies listen to communities and listen to the data that they're producing, because there is a sparsity of commissioned data when it comes to LGBTQ. It's only this last week that we were included in the census, so there will be some proper data following that about size of community.
Yeah, thank you so much. Yeah, very, very good point. And see how the
You're not
census
counted,
affects.
you don't count.
Indeed. So moving on to Chanelle, and very similar kind of theme there. How did you manage the co-production process? It's something that Stef has talked about in the way that she works. That was a really interesting part of the way that you formulated your project with the communities that you're working with. You're on mute. Chanelle, you're on mute.
The host wouldn't let me unmute. In terms of the co-production, I think this is why I think that it is so important to work in partnership with other organisations, in particular third sector organisations. And so because this was a partnership with Black Thrive, I think that that really helped build the links that were necessary for the co-production in terms of connecting with communities and also having spaces to sort of introduce the project and sort of give people an idea of what we were inviting them to do. And then I think because we had a kind of a succession of meetings, so we had the focus groups or the individual interviews, but then we did have contact with people outside of those interviews and focus groups, and then we had the design session as well. We had like a sort of cumulative effect of people kind of getting familiar with what the kind of role or expectations of being part of the co-produced project were. And so by the time we got to the end of the project, it really felt like people had really connected to the idea that they could be part of shaping, designing, and further implementing the outcome of the project, which is what we were really hoping for.
That's brilliant. There was another question related. How did you advertise your initiative? And we saw the posters, but what did you have to do to get people involved? Sometimes it can be very difficult.
Yes, so again, Siddiqui and Taiwo were absolutely fantastic in using all the different media possible to reach out to the local communities. So we used social media a lot, Twitter, we connected with local organisations. So for example, Lambeth College, and we were able to kind of reach out and tell people about the project through there. We had our leaflets, and so I think it's definitely about using all the different media you have possible. And when we actually were meeting with people and sort of asking them about what methods really worked and what didn't, it came up really strongly in terms of social media, which is something that we obviously did use, but didn't think that it was going to be as effective as it was.
Excellent, thank you. And question for Amna. Amna, how did you get the council and other public sector organisations to uptake and apply the projects that you were recommending? What was the kind of process around that?
I think with the process is that usually when we have research, obviously it's funded and we have to take the findings back to our funders, but also it's all applied health research. So it's about making changes, and we're fortunate that we've established a good enough reputation in Bradford now with any research that we do, you know, it's valid, it gets taken seriously. And there's an appetite with the council to make certain changes, say, example, air pollution and air quality. Although our research went into European legislation around air quality, but Bradford, unfortunately, is one of the 30 or so cities in the UK that's still not meeting that target. So, you know, there is that work that we regularly sit on these committees within commissioning and where policymakers sit, and often our research is when we have steering groups, etc., for various projects, members from the council and other statutory bodies sit on those steering groups. So the Act Early is a new collaboration where we're trying to get policymakers, people who can influence, but also broader influencers like architects, for example, lawmakers, etc., all to sit on the same table and try and decide what's going to be best for the city's health and well-being. So in some cases, it's everybody seems to be on board with it. We know we've got issues in the city that need to be addressed, and this is one way that we can do it. But other times it does take some convincing, and particularly like the public, for example, going out and speaking to them, because that's another way where they can influence policy change by addressing their local councillors, etc., and, you know, demanding what they need in terms of priorities for this city. So my research around healthy, happy children, for example, is What we've done is been a grassroots led project right from the start. So the communities have got involved. The steering group was made up of members of the community who expressed an interest in this work, and the hope is that the findings from it will go into future funding bids for this city in terms of our aspirations to be a city of research. So again, with the public having a buy-in, it's we're trying to co-produce research, and I think members, organisations like the council, health, etc., all sort of drifting towards that kind of work because they realise the potential of it. When everybody's involved, it's I think there's better outcomes and results.
That's excellent. Really great to hear. And just reflecting again back to Chanelle, there's been a lot of interest in your presentation. Chanelle, have you found that you've had the same, you've done the research around the sort of needs and the assets that exist in the community. Have you had the take up and the, you know, what are the barriers then to moving on and actually getting projects funded once you've done the research?
Mm-hmm. So it's probably, I should have added this when I wrote the project. As you know, when we were designing this project, I was really sort of clear that when we began conversations with Lambeth CCG about the project, that the funding would have to cover both the co-production element of the project and also fund whatever intervention came out of it, because I think there is a massive ethical consideration of engaging communities in these sorts of projects, which don't necessarily turn into an actual intervention or an outcome that is beneficial to them. So we were really fortunate in that the project was funded to cover the intervention as well. But I know that that's not always the case, and I think that I would probably lobby hard for making commissioners aware of the importance of committing to the entire process, really, not just the kind of consultation exercise, so that you can offer something that you actually genuinely believe is going to be meaningful to the people that are giving up their time and effort to take part in it.
Thank you. That's great to hear that you were able to get that full kind of funding. Otherwise, some of the barriers are just that we have research. We don't have enough research, but then it doesn't get translated into action. So just finally, Charlene, because you've got this population of almost 3 million people, and it's a challenge in all these different community voices. How do you do what Chanelle has done in terms of, you know, you've done the research? How do you get co-production to sort of really happen in GM?
Yeah, so we've got a great structure now set up. We've got voluntary community sector mental health leadership groups set up so they're able to disseminate messages to and from. But I suppose we've got a lot of different groups that are set up in those spaces. So it's about not reinventing the wheel. There's already kind of areas that, you know, groups that are specifically focusing on certain communities, and it's about connecting with them. It's about, as part of the kind of the survey, we knew that we weren't going to get great representation from certain groups, so we had to deliver a series of focus groups to BAME communities, to the disability network, and there was a whole range of networks we had to connect to deliver focus groups. And so it wasn't about just starting from scratch. So for us, it's connecting with the systems that we've already got, seeing where the gaps are, and it's building on that, and it's utilizing the intelligence that we have through those systems already. And being able to look at not just the data we've had, but we need to build on that. So there was gaps in the data and the survey anyway, so we want to build on it going forward and get more intelligence to understand how best to, if we know that a large percent don't know what to do around their mental well-being, what does that need to look like for certain communities, and how do we communicate those messages and the comms side of things to certain communities? So there's a lot more to do. There'll be a lot more testing and learning, but it is just about using what we've got and building on it.
Okay, thank you so much. I'll just hand back to Neha to do some closing remarks. Thank you all.
And another thanks to our speakers, and those were really interesting insights, and it's so great to bring together the different sides of the coin, thinking about communities, research and policymakers working together. I think one of my key thoughts to take back really is around how valuable this research is to highlight intersectional needs. I think all of our speakers spoke to poverty, ethnicity, sexuality, and there's some specific examples such as asylum seekers and refugees that wouldn't have been represented in other data. But also, obviously, we work in an imperfect system, and there are still challenges of getting these community voices valued alongside academic research. But I think hopefully what's really positive that's come out of all of the partnerships and the presentations that we've had today are that there are ways of making this work. And specifically the importance of paying attention to different ways of co-production, of thinking about how you reach out and engage with communities. I think we've had some great examples there. The pointers from Chanelle around authenticity and participation, thinking about using WhatsApp groups and who's got the best message really, who's the best person to deliver this message, as well as making those relationships with lots of different people around the table. For example, your public health leaders, but also people like architects. So I think there's so much to reflect from. I hope that the audience have found it as interesting as we have. And then please do check out the great work of our speakers going forward. We've been tweeting about this, the conference organisers and the Unique Mental Health, and you can also check out the organisations from the sides as well. Thank you very much.